Good evening, everyone, and welcome to another event as part of the Institute of Politics Speaker Series. I'm Steve Edwards, the Executive Director of the IOP, and I'm pleased to have all of you with us tonight for Reinventing American Healthcare with Dr. Ezekiel Emanuel. It's part of our series of ongoing conversations throughout the year where we bring leading players in politics and public policy here to the university to have conversations that hopefully expand and elevate our thinking. We look forward to hearing not only from Dr. Emanuel, but also hearing from some of you during our Q&A portion as we try to get more insights into the American healthcare landscape, where it is, where it's headed, and we look forward to your thoughtful, insightful questions as to his comments as well. I want to thank a couple of people who've been instrumental in this event and been great partners throughout the academic year for us. And they're our colleagues at the McLean Center for Ethics here at the University of Chicago, and Dr. Mark Siegler leads that program. They have partnered with us on a series of events over the course of this year. Some of you may have participated in the McLean Center series looking at ethics and healthcare reform over the course of the last really 32 weeks. So our thanks to them for allowing us to be part of that series, and in return for them helping co-sponsor tonight's event. I want to let you know that after this event there will be a reception. There are also books available for sale, so we invite you to stick around for that. And without further ado, let me introduce the person who will be welcoming officially Dr. Emanuel to the stage, and that is Hassanin Alkersan. He is a first-year medical student at the Pritzker School of Medicine here at the University of Chicago. He's also an advisory board member of UCSC, which is the University Community Service Center. He graduated with highest distinction from the University of Michigan in 2013, where he double majored in cell and molecular biology and Arabic and Islamic studies. Please join me in welcoming Hassanin to the IOP. Hassanin?
I'd like to start out by thanking the Institute of Politics, firstly for hosting a range of really incredible events and giving access to the students here, and specifically for directly engaging medical students at this critical juncture, or collision, some might say, of healthcare and policy. America's healthcare system is neither healthy, caring, nor a system. There's profound truth to be found in these words by the late Walter Cronkite. Regardless of where one identifies on the political spectrum, there's no denying that the American healthcare system, as it has existed, is economically untenable, relatively inefficient, and egregiously inequitable. Of course, the changes that have been implemented in the Affordable Care Act elicit differing reactions depending on with whom you speak. But in my short time as a medical student, I have found that, like most other areas of politics, few really understand the complexities of the ACA. Luckily, today I have the privilege of introducing a man whose career has combined the fields of medicine, policy, and ethics, yielding insight on this topic that is unique, informative, and timely. Dr. Ezekiel Emanuel is a senior fellow at American Progress and the vice provost for global initiatives, the Diane S. Levy and Robert M. Levy University professor, and chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania, and he is also an op-ed contributor to the New York Times. He was previously the founding chair of the Department of Bioethics at the National Institute of Health and held that position until 2011. Dr. Emanuel received his master's from Oxford University in biochemistry after attending Amherst College. He then received his MD from Harvard Medical School and his PhD in political philosophy from Harvard University. After completing his internship and residency in internal medicine at Boston's Beth Israel and his oncology fellowship at the Dana-Farber Cancer Institute, he joined the faculty there at Dana-Farber. Dr. Emanuel has also served on President Clinton's Healthcare Task Force and the National Bioethics Advisory Commission. Dr. Emanuel offers an important perspective regarding the American healthcare system, also having served as a special advisor to the Obama administration on healthcare reform, and he has recently authored a new book, Reinventing American Healthcare, How the Affordable Care Act Will Improve Our Terribly Complex, Blatantly Unjust, Outrageously Expensive, Grossly Inefficient, Error-Prone System. I think that title gives you his experiences and also all the problems that we have in our system. And believe me when I say these are just a sliver of the accomplishments. They only gave me 3 minutes, so I couldn't list everything. But join me in welcoming Dr. Ezekiel Emanuel.
Thank you. It's a great privilege to be here, and many people have told me this is the university I should have gone to. The only problem is it was in my hometown, so couldn't go here. So I want to begin with a trip down memory lane. I mean, there is a reason we reformed the healthcare system. Sometime now people, sort of suggest we should look back. We getting too much feedback here? Wistfully on the old system. Oops. This is a disaster. In 2008, we had a debate because the system was totally dysfunctional. 50 million people in America without coverage, 38 million of them American citizens. We had quality that no one could be proud of. We had great institutions that could do amazing things, but terribly uneven quality, and lots of people dying from iatrogenic causes. And we had costs completely, totally out of control. There was a reason we reformed the system. We spent 14 months in that effort. I was recently on a panel and someone said, well, we wish the president had done more to work with the Republicans. Let's be clear. Right? We spent the first 9 months trying to get Republicans to participate. Some of you may remember a phrase called the Gang of Six, where Senator Baucus met with 2 other Democrats and 3 Republicans, went through all the spring and into the summer, making no effort. Now, I've been asked, you think that was deliberate, or do you think that was, just couldn't come to agreement? I have no idea. All I know is we spent a lot of time trying to make this bipartisan. My boss, Peter Orszag, who was head of Office of Management and Budget, had a special relationship with Olympia Snowe, Republican senator from Maine, and he shuttled back and forth with her. She often produced a list of wants that had to be in the bill, and it was my job to make sure those things were in the bill. And in the end, we got all of her 10 demands in the bill. She voted for the bill in committee, in the Finance Committee, but not when it hit the floor. It was not for lack of effort. Now, there were a lot of issues in that were debated and a lot of tough things. As I've said in many fora, the Affordable Care Act, like any piece of legislation, is not going to be perfect. There is no piece of legislation out of a democracy that's going to be perfect. They're all got compromises. And the Affordable Care Act had many compromises. Some of them were good, and some of them, many of us wish had gone the other way. In the book, I detail some of a few cases, and I'll just tell 2 stories. One involves David Axelrod, so I'll tell it now in his absence since he can't respond. The healthcare team advising the president roughly broke down into 2 groups. The sort of people from HHS who had a strong commitment to expanding access and a commitment to a lot of the existing programs, and then what was crudely or broadly called the economic team, people from Office of Management and Budget, people from the National Economic Council. Now, those of us who were on the economic team advocated that we should reform something called the tax exclusion. Now, tax exclusion is one of those little small things, technical, only policy wonks could love. But it turns out to be an incredibly important insight and window into our healthcare financing system. So let me tell you a little bit about how we got the tax exclusion. Probably none of you, maybe 1 or 2 of you, know what the tax exclusion is. In the midst of World War II, we sent, and sometimes it's hard to believe, 17 million men overseas to fight. And as a consequence, there was huge labor shortage. We were turning all sorts of material into the war effort. And there was incredible inflationary pressure. In 1942, the Congress passed a law, wage and price controls. And that limited how you could increase wages and increase prices for various things. And that, interestingly, had a small exception in it. Employers wanted to get workers and wanted to be able to pay more to get workers because they were under extreme pressure to produce. But they couldn't raise wages because of the wage and price limits. The exception said that, well, we won't consider it part of the wages, and we'll allow you to raise if you provide insurance, health insurance, and it doesn't exceed 5%. Can I do something here for the back feed? It doesn't exceed 5% of the person's wages. Suddenly, providing health insurance became a way of attracting workers, and a lot of employers began to offer health insurance. After the war was over, several rulings by the Labor Relations Board said, well, if you negotiated on health insurance and it was part of the wage package, you had to honor that. Unions began to negotiate to get health insurance. And then in 1954, the IRS ruled, or Congress passed a law and the IRS wrote the regulations saying that this health insurance provided by an employer, that was not to be included in your income when it came to taxes, both income taxes and payroll taxes. That's the tax exclusion. We're excluding the payment on health insurance from your income tax. Suddenly, overnight, $1 in health insurance became much more valuable than $1 in wages because the $1 in wages was taxed and the $1 in health insurance wasn't. And it had the predictable effect, big expansion in employer-sponsored insurance. It also had another predictable effect. People got more and more insurance and less in terms of wages. By the time we were debating healthcare reform, the tax exclusion had grown. It is the single biggest tax break in the American tax code. It's worth $250 billion. To compare, for those of you who want to keep track, the mortgage deduction, sacrosanct, $70 billion. So it's an enormous. It fuels a lot of the healthcare inflation we've had, and it also has other perverse effects, keeping wages, cash wages, suppressed. Well, the economic team thought, you got to do something about the tax exclusion. So one day in July, a hot Friday, July afternoon in Washington, D.C., the core health team was meeting in the second floor office in the West Wing. Phil Shalero, who at that time was the head of legislative affairs, the guy negotiating with Congress and trying to navigate the bill through Congress. And we were talking about who, Lord knows what. The president came in. It was a sort of thank you session, sort of keep the morale up session. And we started talking, and he was talking about how he was sure healthcare reform was going to pass. Mind you, this is July, just before all the congressmen went home and confronted all of those vocal town meetings. And he was talking about how lucky he felt and how healthcare was definitely going to pass. And it was like most of us were just slogging away and thought things were not looking so great. And then some point we moved off the pleasantries onto substance, and I turned to the president and I said, one of the important things about the bill is you want to have cost control. This is one of the major motivations he had in introducing the Affordable Care Act, to get costs under control, to keep the federal budget from bankrupting the country. And I said, in the public sector, on Medicare and Medicaid, we have a lot of flexibility, but over the private sector, which after all insures more than half the people and accounts for more than half the dollars in the system, you have very little control. And the best, most effective method, it's not a scalpel, it is a bit of a pickaxe, is the tax exclusion. Well, we got into a discussion about the tax exclusion, and the next week we educated the president more about it. And I explained to him that, he mostly heard about the tax exclusion as a great way to raise revenue, right? If you limit the tax exclusion, there's a lot of money, $250 billion there. But from our perspective, the economic team perspective, is a great way to keep healthcare costs down. Well, the other side inside the White House, the other part of the health team, and especially the political team, which David Axelrod headed up, hated this idea. Why did they hate that idea? Well, as David Axelrod liked to remind us, the president campaigned against John McCain, who wanted to get rid of the tax exclusion entirely, with over $100 million worth of ads saying, you know, the Republicans are going to tax your health benefits for the first time ever. And this was an anathema. The president was going to go back on his word. And whatever else you think of President Obama, one of the things I can tell you that is true about him is his word is very, very sacrosanct to him. A lot of times in meetings he would say, well, what did we say about that in the campaign? Or what did we say about that in the last speech? To make sure that what we were going to do was consistent with his previous policies. Because he was very clear the American public should be able to trust what he had said. But this was going to be a case, and from the political operative standpoint, of going against what he had said in the campaign. In the end, and I think one of the good parts of the bill, there is something called the Cadillac tax. And the Cadillac tax does take aim at the tax exclusion. A little roundabout. It's, after all, politics and sausage making. And it's the last piece of the Affordable Care Act to go into effect. In 2018, very high-cost Cadillac plans have if they go over a certain limit, which is $27,500 for an insurance plan for a family of 4, there's a 40% excise tax on everything over that limit that the employer has to pay. And we can already see the effect today because employers are trying to rearrange their insurance to keep the premiums down over time. So in my view, that was a case of policy, wise policy, triumphing over politics. And it was a very important, I think, element of the Affordable Care Act. Let me talk about an element which didn't get into the bill, and that's medical malpractice. This actually, the Affordable Care Act was a unique opportunity to get medical malpractice. Now, you should remember that medical malpractice is not something traditionally done at the federal level. It's a state activity regulating the malpractice rules, and we have different rules in different states. Nonetheless, you had a president who was for malpractice reform. When he was a senator, well before he was running for president, he had introduced a bill with Hillary Clinton and wrote an editorial in the New England Journal advocating for malpractice reform. There were people, myself, the other doctor who was working in the National Economic Council, Bob Kocher, who were for malpractice reform. People like Larry Summers and Peter Orszag thought, well, maybe it would create a good incentive if we tied malpractice reform to producing higher quality care, and that would be a good way of trying to both attend to doctors' needs but also improve the quality of the system. We put together a group and created a set of options. One of the things you notice when you try to do a set of options around malpractice reform is we know woefully little about how the various options would actually affect practice, reduce healthcare costs, improve quality. Really, really little. It's an area. Nonetheless, two things fundamentally prevented malpractice reform from being included in the bill. And they're both political. First is, couldn't get any Republicans to play ball. Now, if the Republicans wanted to join the bill and said, you know, we got to get malpractice, that's going to be a major piece of getting us on the bill, probably would have been in the bill. No one had it was the kind of horse trading that was foreseeable. And the second group was the doctors, the American Medical Association. Now, in public, the AMA was all malpractice reform really important. Turns out in private, where the real negotiation happens, not so top of their list. top of their list was money, fixing the sustainable growth rate, SGR. Sustainable growth rate is another thing that only a policy wonk could care about, but it's the way Medicare pays doctors, and every year it's supposed to go down because what they pay doctors, because there's a complicated formula that is supposed to assess how much doctors get paid based upon what were billings last year. Every year, Congress never puts the cuts in, but they don't change the formulary, so the cuts accrue and accrue and accrue, and they're now worth about, there would be a total cut of about 24% to each doctor. So the AMA was like, we gotta reform the SGR, that's top of our list. So every time they would go into the back room with people like my brother, you know. So one day I was walking into my brother's office, just checking in sort of towards the end of the day, and he's standing up in front of his desk, and you know, you probably don't know this about my brother, but when he was a little kid, he was an utter slob. Just total mess. My father used to say about him, you know, you go into his room and you look under all the stuff, you try to find, where's Rahm? Now, as an adult, he is like Mr. Super Neatnik. His desk in the West Wing never had a piece of paper on it overnight. He got cleared, the desk was completely cleared every night. Just completely, totally transformed. So he had, when I walked in this one day, 2 pieces of paper on the desk, that's all. And he was looking down, he says, you know, what's up? And he had tasked me with doing some calculations on various alternative reforms, and you know, what if we only covered this group or that group, and how could we restructure it to save money? So you know, I sort of reported into him about how those calculations were going, and then he says, and everything else good? And I said, well, you know, I've been working on this malpractice, and I got about that far in. And he says, shut the blank up, right? We're not doing that, right? Every time the doctors come in here, all they talk about is SGR and money, and they don't talk about malpractice reform. I don't need malpractice in the bill, and I'm not alienating another one of the Democrats' base to get the bill passed. And that just told me everything we needed to know about malpractice reform. If the Republicans weren't going to make it a requirement for their joining the bill, and the doctors weren't going to make it a requirement for their joining the bill, there was no way it was going to be in the bill. It was just that simple politics. So in the end, without a vote to spare, and it's very important for those people who said, well, why didn't you do this, and why didn't you do that, and what about the public option, and what about, we didn't have a vote to spare, right? You couldn't have larded more on this bill. It just wasn't possible. We've spent 100 years trying to get healthcare reform passed in the United States, and it isn't possible to do anything more. Now, if you look back, it's a miracle this bill happened, a veritable miracle, right? President Obama had 60 votes in the Senate, right? That's what you needed. He had a majority, and he had Nancy Pelosi in the House making sure that there weren't going to be lots of competing bills. There was only going to be one bill out of the House. And in the Senate, they passed the bill on Christmas Eve. And then we lost Senator Kennedy's seat unexpectedly. We didn't have a vote to spare. We couldn't go back to the Senate. The only way was to get that Senate bill passed by the House. There was no chance for any more. So how is the Affordable Care Act doing? Well, on the 3 big metrics, it's doing well, 4 years out. First, on access, right? Exchange rollout sucked, let's be honest, right? 2 months, it was basically inoperative. And nonetheless, 8 million Americans signed up for coverage in the exchange. What does that tell you? People really, really, really want affordable health insurance. And they're willing to put up with a lot to get it. The idea that somehow Americans really, they were going without insurance because they really wanted to rough it. 8 million Americans signing up despite the first 2 months not being able to operate tells you a lot. 3 million kids under 26 on their parents' plan. 3 to 5 million people buying coverage in the private market. millions more on Medicaid. Again, despite many states not expanding Medicaid. You know, lots of people say we're really concerned about those 500,000 or maybe 2 million people with, you know, private insurance, who the insurance companies changed the policies and they had to abandon plan and had to get another plan. First of all, that wouldn't have been a story at all had there been a functioning exchange. And the Republicans all concerned about these 500,000 or 2 million people. Why aren't they concerned about the 5 million people in states that won't expand Medicaid? So we've had a big expansion. And by almost every calculation, and especially, you know, the standard is now this Gallup poll question, consistent decline in the uninsurance rate since the start of the exchanges, lowest level since before 2008, and about 9 to 12 million people of the number of people who bought coverage are people who previously didn't have insurance. Big, big improvement on access. What about quality of care? Well, one of the parts of the bill, which I'm very proud of, is we had a penalty in the bill on readmissions. So one of the things you might not know is that if you were a Medicare beneficiary and you went into a hospital like the University of Chicago hospitals and you were discharged, your chance of returning within 30 days to a hospital before the ACA was roughly 20%, 19.5%. Not very impressive, right? If the cell phone you had, if 1 in 5 times someone bought a cell phone had to return it within 30 days, you would be livid. You might even go postal, right? But that's the way. So we had a penalty in the bill that kicked in a couple years ago that hospitals that didn't reduce their readmission rate would be penalized. And that readmission rate has, since the penalty went in, gone down, down, down. Now, they haven't fully redesigned care for that, but lots of places, I can tell you, including my own hospital at the University of Pennsylvania, thinking of lots of interesting new ways of trying to care for those patients when they leave the hospital. Similarly, one of the, again, something that I was heavily involved in and very proud of is something called the Partnership for Patients. With $500 million from the Innovation Center, which was another part of the bill, Don Berwick devised a plan, and we all worked on it, to actually address the issue of hospital-acquired infections, falls, medication errors, and a whole series of other things. 3,700 of the roughly 5,000 hospitals in America joined onto this Partnership for Patients and committed themselves to fixing these problems. And the results after 3 years has been pretty remarkable. Ventilator-associated pneumonias down 50%. Early elective C-sections before 39 weeks with no medical reason, no distress on the fetus's part and no problem in the mother. Elective C-sections down over 50%. Lots of other stuff declines. Overall, in these hospital-acquired conditions, a 9% decline. And now this year is going to kick in a penalty again for hospitals that don't perform better on these hospital-acquired conditions. And we are going to see, I think, going forward, a pretty dramatic improvement on quality. Finally, on the cost. Medical costs have come down over the last few years, especially in the government programs, Medicare and Medicaid. Medicare programs over the last 3 years have been flat per person. The Part D and Part B premiums that seniors pay have basically been flat over 3 years. Medicaid has actually seen a per person decline in costs. We're not out of the woods. A lot of that was the recession. Some of that was what we call in the economics team price wax. We're just reducing the prices we're paying for things. But we are in the midst of a transformation of how care is being delivered. I go all over the country, and right after the Affordable Care Act passed, people, it's like, you know, won't really make a big difference. It's all about access. Then, after a couple of years, people's like, you know, it's unclear what real impact this is going to have on us. It does have these, you know, things on readmission and then about a year ago, it's like, what's in the Affordable Care Act? Can you educate me? And within the last 6 months, it's been, tell me what I need to do because the system is changing. Tell me, help me to change. And all over the country, there's a lot of change going on in how we deliver care. We're not there, After all, the system is too big to change overnight. But it's part of a process. And we are in the start of the process. So the end of the book, the last chapter in the book, is called Megatrends. And I try to take a look into the future, 2020 and beyond. And as I introduce that chapter, I make quite clear that I know the problems of making predictions and looking into the crystal ball. After all, one of my colleagues at the University of Pennsylvania is a man named Phil Tetlock, who most of you don't know, but he's the world's leading expert on forecasting. He once, his most famous project is he asked hundreds of economists to make lots of predictions, quantitative, detailed predictions, 28,000 predictions, so a lot of data. And he found out a lot about making predictions. First of all, economists, they're better than dart-throwing monkeys, but not by much. As a matter of fact, they're no better at making economic predictions than you, intelligent people who keep up with the news. And finally, by the way, the more famous you are, the less good your predictions are. So with all of those caveats, I make a lot of predictions in the book. In part because all of us have to make predictions. The hospital over there, do we build a new bed tower or not? It's making a prediction about what the future will be, right? I just talked before this session with medical students. They're probably making the biggest, the longest term bet, the next 40 or 50 year bet. You know, do I want to go into medicine? What specialty am I going to go into, et cetera? Hospital groups. Do we join physician groups. Do we join a hospital? Do we stay separate? Venture capitalists. Do I invest in this biotech company or do I invest in that IT company? So everyone's making predictions. So here are my 6 predictions, and I'll end with that. Prediction number 1. Health insurance companies, as you know them, as I know them, going away. Dead. By 2025, they will be out of the insurance business. That is, they will no longer be simply taking premium and paying doctor or hospital. Either they will be extinct, truly extinct, because they didn't see the change coming, or they will be selling their analytic skills, or they'll have partnered or bought or owned or employed doctors and hospitals in delivering care and become more like Kaiser, more an integrated delivery system. Second, most of the costs in the healthcare system are related to chronic illness. 84% of all the healthcare dollars are related to chronic illness. If you want to improve quality and you want to decrease costs, you have to focus on the chronically ill. So I see over the next 5 and 10 years a real focus on people who have chronic illness. Congestive heart failure, coronary disease, emphysema, diabetes, asthma, hypertension, cancer. People with those conditions are going to get a lot of attention to keep them healthy. Because keeping them away from specialists, keeping them out of the emergency room, keeping them out of the hospital is going to be a key element of saving money. And once we've got good care for the chronically ill, the next wave, we're going to focus on people with mental illness, depression, anxiety, and those disorders, because those cause a huge amount of the healthcare bill. I also see a terrific rise in digital medicine, home monitoring, monitoring for compliance with medications, monitoring in all sorts of ways that's invisible to most people on a daily basis, going to go up tremendously. Home emergency room visits. Instead of going to the emergency room visit, you're going to log onto your webcam and talk to a doctor. Already going to proliferate hugely, and a space of enormous innovation over time. One of the consequences is if the readmission rate goes down, if the hospital complication rate goes down, if we take care of people with chronic illness, if we can do more digitally, we're going to be having less of a need for hospital beds. And I think hospitals are going to close. That's not going to be a bad thing. They're going to become long-term care facilities, they're going to become physician offices, and lots of other possibilities. And we will simultaneously improve care. Most of us don't want to spend a night in the hospital, even if we are sick. We should not view them as a great civic institution. I believe that we're going to see a big shift of people from getting their coverage from their employer to going into the exchange. Now, the IRS last week made that a little more difficult, my prediction, but I think that rule is probably up for reconsideration. I actually think we're going to see an era of no healthcare inflation. The per person costs of healthcare are not going to go up faster than the economy. And they've gone up faster than the economy for over 50 years, since the 60s, except for 1 year. And I think we're going to see a moderation. That's going to be hugely important for you. Your take-home pay is going to increase as a result. Hugely important for the federal budget. Hugely important for states and their ability to finance education and other things. But I do think healthcare inflation is coming down. The last is probably my weakest prediction. Medical schools actually might change. Hasn't happened in 100 years. Slowest evolving organism in the universe. But I do believe we're going to have to fix and change how we educate medical students, interns, residents, because right now the system is really not responsive to the kind of healthcare we're going to have to provide. We're going to need more team-based training and team-based care. We're going to need to train people on how to use data more effectively, how to manage data, how to manage change, how to be team leaders, how to actually understand costs and benefits of things. So I think we're going to have to change a lot. And the last one I like to put is, when I trained as an oncologist, I trained at an illustrious institution in this country, and the training period was 3 years. How much of that was clinical training? 1 year, right? 2 years were supposed to be research. And when you find out and you go back into the dusty records, well, how many of those people who started the fellowship ended up doing research, right? About a third, right? So we're taking this group of super talented people, requiring them to spend 3 years, 2 of which are largely irrelevant for their future career. Not a very efficient way of training people. So it seems to me that whole system of training people is going to have to change pretty markedly as we go forward. But I will tell you, that's the one I see on the slowest boat, just because medical schools are very, very slow evolving organisms. Thank you very much, and love to open it up to questions. A question.
Hi, thank you very much. I'm wondering if you
Tell
could
me who you are, just so.
My name is Mary Stoner Saunders. I used to work at this illustrious institution, and I no longer do, but I come for these nice, free, and informative gigs.
Great.
I'm wondering if you could talk about the intersection between healthcare and human services, particularly in regards to chronic conditions that you just mentioned in your prediction, and how you think that may impact reimbursement policy, particularly when those chronic conditions are so driven by social behavioral determinants of health, but they're not compensated for in the medical care system right now. How do you see that evolving, and do you see funding going more out to public health and human services just to support the work that's done in medical care centers? Thank you.
That's a very complicated question, but I do. So if you're a health insurer or a provider of care, and one of your requirements is that you're going to have to provide care more efficiently and cheaper, and these people with chronic illness and chronic mental illness are big users, you are going to redesign not just your care, but how you do things. Because the most important thing to you is to keep them healthy and to keep them out of the hospital. And as you point out, a lot of this has nothing to do with traditional health, but it has things to do with, if you've got someone with bad COPD or asthma, in the summer they need an air conditioner. Well, under the current system, you can't buy them an air conditioner. Under the future system, if you're getting paid capitation, you will buy them an air conditioner. Similarly, you're probably going to invest a lot for your diabetic patients in trying to get them to eat better and to begin exercising. Now, we say that cavalierly, like we're all so great about changing our behaviors around eating and running. Most of us make New Year's resolutions and promptly violate them because changing your habits around these things is darn tough. And we don't do it so easily. And we should not blame other people because they don't do it so easily. But you will, I believe, as a health system, begin investing a lot more in getting these people to change their habits. And that's going to require, I don't know whether we call it social services, but it's going to require much more than just, passing out pills and admitting people to the hospital. I see that. The second place I see a lot of it is if you think people are sticky. What do I mean by sticky? Once you buy an insurance product, you're going to stay with the insurance product. How many of us change, other than changing jobs, change our insurance from year to year? Unless your insurance company pisses you off, right? You go through the path of least resistance. We know this from behavioral economics. It's inertia, right? It's Newton's first law. And we all live this way, right? So one of the impacts, I believe, in the future is once I'm in an insurance company, they're stuck with me. I'm stuck with them, but they're stuck with me. Now, it's not stuck in any, no one's forcing you, but suddenly they're going to think of you much more long term. And I think that's going to get them to do things that they haven't done before. You hear this under the rubric, now it's just a label and no one's really doing much about it, population medicine. But just think about it. If one of your big problems is, you know, we've got a lot of overweight kids, maybe we ought to partner with the school to try to do something about it. I think that kind of innovative thinking, it's not for tomorrow, but it is beginning at the end of this decade and into the next decade. And so I do see that as a very important avenue of change.
Okay, thank you.
Hey, thanks for coming. My name's Colin. I have a specific question, I guess, about when you wrote the bill or when you guys, interstate health insurance competition, buying insurance across state lines. It seems, to me as an outsider, it seems very common sense that that is something that could benefit. Why was that not included? What is your viewpoint on that?
Irrelevant what my viewpoint is. So let's go back. How are people elected to the Senate?
By their state.
Yeah, by their state. What it goes on in states? They regulate insurance, right? You got this problem, okay, that senators are not going to undercut their state insurance commissioners. Not likely to happen. And that's what interstate sale of insurance does. Unless the state, the governor and the state insurance commissioner want to do that, which most of them don't like to give up power, no one voluntarily gives up their authority, that's why it's not in the bill. So you could imagine the following scenario, which I think is a plausible path forward. Instead of every state having its own exchange and the federal government, either one of two things is probably going to happen. Either you're going to have, I think, evolve to regional exchanges. The infrastructure for an exchange doesn't need to be, once you've created a good one for a state, it can expand. And then you might have deals across states about having an insurance company offer coverage in more than one state without having to do things. There are lots of protections. States with high regulation of insurance companies so that they do the right thing, they actually have lots of requirements on them, don't want places that have low requirements to come in and upset the apple cart and basically they think prey on their state citizens. And the reverse is also true. So there's lots of political reasons why people who pass these bills not so keen on that idea. So that's just politics. It's just politics. Forget the substance.
Yeah.
It ain't going to happen.
The ACA as a whole could have had certain restrictions. It does have certain restrictions. So that seems like a simple answer to that. But I understand everything
This was
else
not
you're
one.
saying.
This politics.
Yeah, thank you.
My name is Robert Bornholz. Actually, I'd like to continue on the last proposal that looking forward to how there probably will be a lot of political pressure to repeal or replace the Affordable Care Act.
Done.
How
No.
would you preempt that? And one could imagine very simple ways to morph it into a more market-oriented solution. And one is the tax exclusion, end employer mandates, have refundable tax credit,
Okay, let me just.
and then across the competition across state lines.
We are not repealing the Affordable Care Act.
Well, that's why you need to preempt.
Ain't going to happen, okay? And one reason it isn't going to happen, there are two good reasons. One, right, January 2017. President's in office until January 2017. You are not getting a bill that he is going to sign to repeal it. Now, in January 2017, well more than 25 million people, I believe, are going to be in the exchanges. Many other people are going to have to benefit it in various ways from the Affordable Care Act. There's no way you're going to repeal it, right? Unless you have a replacement. And guess what? You don't have a replacement. The Republicans have never had a replacement that has lasted 24 hours in oxygen, okay? And I'll tell you why. It's a really simple thing. So the last replacement, do you know what the last replacement proposal was? Burr, Coburn, and Hatch had a bill that they put out. It lasted exactly 24 hours. I wrote an op-ed in the Times pointing out this simple fact that if you look at their bill, the average middle-class family will have to pay $1,500 more. Poof, end of bill. Okay, now why don't we have a Republican alternative? It's a really simple reason. The Affordable Care Act is the Republican alternative. That is it. And I'll tell you why. One of the points I make in the book is you go back in history. Let me give you a Republican bill. Provide people with subsidies to buy private health insurance, and those subsidies are linked to their income. And they have to buy private health insurance for coverage. Sound like anything you ever heard of? That's Richard Nixon, 1950. Okay? You've got that version of a bill. Now, he didn't have a mandate. He was still under the idea that this could be voluntary. One of the things we learned in the 50s, 60s was couldn't be voluntary. If you really wanted it not to have a death spiral, it had to be mandatory. He got to mandatory in 1973. Exchanges with individual mandate, that came from the Heritage Foundation, the Republican side of the aisle. The Affordable Care Act is a market solution. You create a market called the exchanges. Private companies offer insurance products. Individuals decide which insurance product they want, and those people who can't afford it, they get subsidies linked to their income. Now, if that doesn't sound Republican and market-oriented to you, I don't know what will.
Well, but it does increase regulatory complexity, and it increased employer mandates.
Excuse me. This is a $3 trillion industry. Do you know how big healthcare is? $3 trillion. Let me put that into context for you. Because as smart as this audience is, right, even the economists at the University of Chicago don't deal in trillions every day. There's only one group in the world that deals in trillions every day. They're at OMB, and we had no idea how big $3 trillion was. The economy of France, that's $2.5 trillion. All 66 million French people. Everything they eat, drink, buy, drive, we spend more. And the French economy, that's the 5th largest economy in the world. The American healthcare system is the 5th largest economy in the world. You are, per force, going to have regulation of that big an item. There is no way you can't have a lot of government involvement with it. There is no way. So when people say to me, oh, there's a lot of government interference in the Affordable Care Act, how could it be otherwise? It is so enormous a system, so complex a system. You can't do in a complex system, oh, just make it simple. That is a fallacy. That's an illusion. That is a nightmare. Make it simple.
Thank you, Dr. Emanuel. I'm Yang Cheng, PhD candidate in physics. So I guess as a particle physicist, I do deal in trillions, just not dollars.
You do in sub-trillions, 10 to the minus 12.
Thank you. So earlier you mentioned that the Affordable Care Act is an imperfect bill, as any bill, but it was the bill we could get it passed, and there were compromises made. Some of them you do not think are optimal. Now that it is the law of the land, and through its implementation process, do you think anywhere down the road there would be the political room to correct some of the compromises? And are these amendments more or less likely if the Affordable Care Act performs well or worse down the road? Thank you.
It's a really great question. So 2 parts to the answer. The first part is, if you look at Massachusetts, where they passed Romney Care, right? After they passed it, they had to have 6 additional revisions. And they're going to, revise and revise and revise. Revision is inherent, Okay, one of the, that subtitle that was nicely quoted, I don't use the word, how the Affordable Care Act will solve all these problems of the system. I talk about how it'll improve, because there is no solving, right? Again, one of the things about a $3 trillion system is, you attend to this, there's an unintended consequence, or there's an effect you didn't anticipate, or it was worse than you thought, or it was better than you thought. So we're constantly going to have to tinker. Unfortunately, the ACA has been involved in this, terrible partisan battle, and so we can't fix things which are obvious. By the way, if you talk to people on the Hill, right, away from the glare of the TV lights, one-to-one, there is a large overlap of Democrats and Republicans about things that need to be done, like moving off the fee-for-service payment system, et cetera. Problem is, we're stuck in politics. Now, hopefully, this will be the last election we have on the ACA. As has been recently pointed out, you have not heard about repealing the ACA very much. It's been sort of going down, the amount that's been. And maybe by November, it will disappear. I think one consequence of that, you'll see a lot more states right after November begin talking about implementing the Medicaid expansion. I make a prediction in the book about how many that'll be. I think there's going to be a lot of states now looking at that. And my hope is that with that out of the way, we can get small fixes melded into other laws and things over time. So it has to be more depoliticized, and it has to look just like, well, it's here to stay, so let's fix it and make it better. But that'll take time.
Thank you for a very interesting presentation. I'd like to ask you to take a slightly different, perhaps wider, or distant, I'm not sure, perspective. It's my understanding that a recent poll showed that about 2/3 of the physicians in the United States support single payer, and many, many Americans do. Hey, there's
Not
numbers
2/3
on
of the
that. Hey, there's
it's not
numbers on
2/3 of the
that.
doctors. It's just not.
Anyway, I'd like you to tell us a little bit about how you feel and how soon we're going to have a single payer.
We're not going to have single payer. It's just that simple.
Maybe not in your lifetime, but in my lifetime.
Yeah, maybe. Can I have the pills you're taking? Let me remind you, we had not a vote to spare, and we could not even get the public option in. It ain't happening. We have been trying for 100 years to get healthcare reform in the United States. A whole variety of proposals. Not happening. Now, people have very different views about what single payer means. And I don't know whether you mean, well, the federal government will, I had what sometimes is called the single payer proposal, which is the federal government will give everyone a voucher, they'll go into the exchanges and buy insurance. I think most single payer advocates, that doesn't sound very single payer-ish since it still has the insurance companies present, et cetera. I don't think that's happening, although I do think we will have something more like that with a lot of employers giving people a defined contribution or a voucher to go into exchanges and buy insurance. But that's typically not what, if you mean Medicare for all, that ain't happening. And one of the interesting things that I think advocates for single payer need to think about is, over time, the sort of traditional Medicare has been going down, and people buying insurance, the Medicare Part C, has actually been going up. It's now about 1/3 of the program. I just don't see the political possibility in the United States. There would have to be some major catastrophe, and I just don't see that happening. So I don't think we're going to get single payer, politically untenable, and I just don't see how the ducks line up. And so if, first of all, I'm a betting man, and I'm happy to take that bet. And second of all, I would think that the Affordable Care Act is the law of the land. We ought to work within that framework and try to make it as good as possible. There are many things that can be done through the Affordable Care Act to get the kind of system we want. One where everyone can get coverage, that's providing consistently high quality, and that has reasonable costs. And so I see no big reason to push out of that framework.
Hi, my name's Phil Verhoef. I'm an ICU physician here at the university. And it seems to me that, for instance, the problem that the VA is having right now is exactly created by some of the restrictions or guidelines that you propose in Obamacare in terms of, say, readmission rates. You know, effectively, what you're doing is creating metrics that people then are motivated to game in order to not lose their jobs or not be financially penalized. And so, given that there's not a lot of evidence that a lot of those things actually either cut costs or improve quality, and that we're seeing this sort of thing sort of play out right now, I guess I worry a little bit about that. And then, by extension, I wonder if there's ever a way to motivate physicians or anybody without a financial carrot.
Okay. Really good. So first of all, I think, thanks for reminding me about the VA. There's another good reason you're not likely to get single payer in a short order here. We know from behavioral economics and psychology and lots of studies of regulation that you set out a benchmark, a metric, whatever it is, and people immediately try to game that benchmark. That's a very important understanding, and it's very important for how we should go forward with quality metrics, in my opinion, that you shouldn't stick to just any. But I don't see any alternative than to create some metrics that we think are valuable and important and keep people, measure it, and keep people accountable for them. Maybe you have an alternative way of ensuring high quality and knowing you're getting high quality in the ICU at the University of Chicago. It seems to me, of course, people are going to game the system. Well, we won't measure for infections or we won't do other things if we have to be assessed. But I don't see an alternative than measuring, and by the way, being as completely transparent as we can be about actually making the metrics. The problem in the VA system is it was a widespread culture of gaming the system that everyone knew about, apparently, and was still tolerated in the system. Now, maybe, again, I throw out the challenge to you. It seems to me we ought to measure more and change the measures frequently. One of the things you know about measurement is when people get up to doing very, very well on quality, you got to change the metrics. There's no virtue in doing certain things. And I agree with you. If you can go to the Medicare Hospital Compare site and you can look at there they collect data in a variety of areas on hospital performance, supposedly on quality metrics. And what you say is, largely true. You look at 30-day treatments related to MIs, and some every hospital's above average, by the way. Every hospital's above average. And many hospitals they only report selected data. They don't report all their data. And many hospitals will report, we don't have enough data on MIs. What are you doing if you don't have enough data on MIs? It's like the most common thing a hospital does. If you don't have enough data on MIs, they're obviously playing a game. They're hiding their data and their performance. But that's not to say we shouldn't be measuring. There's no alternative to measuring and trying to be transparent about the measurement and trying to be rigorous about it and cracking down, frankly, on people who are doing what is, by all accounts, fraud. So you got an alternative? Love to hear it. But how do we know that you're doing a great job in your ICU unless you have data and you can show me data? And by the way, I think the push for data is going to become much, much, much more important. And we're finally actually going to get this real push for quality data. Why? Well, in the past, the big brand names in a city, they didn't want quality data collected. They were the brand name. Everyone had to have them in their insurance, right? Well, now, if you were you were the number 2, the Avis of whatever, right? You wanted the quality metrics collected so you could show my quality is just as good as number 1. But number 1 didn't want data. Now number 1 wants data. Why does number 1 want data? Well, they charge a premium typically, those brand names in a city, and they want to show their quality is really good, worth the premium. And so I think there's now finally going to be a push throughout the system to try to get much more and reliable quality data. On your last point about how to motivate and get docs to do the right thing, I agree with you that we have not thought through enough about non-financial incentives to motivate doctors. One of the points I like to make is, You know, we have done a very good Darwinian job with most medical students, right? You got to do great in high school to get into a great college. You got to do great in college to get into medical school. You got to do great in medical school to get into a great residency, and on and on and on. And then, once they get into practice, we stop. We stop measuring them to be number one in their class. Why do we cultivate this Excel gene and then throw it away? So it seems to me one of the things we should all want is, yeah, let's evaluate them. Let's make it transparent so everyone knows who's number one. The bottom will come up. Some people may get out of it because they're not able to do it. But I think that transparent performance, most organizations that have done it with doctors have seen remarkable positive changes. But I also do believe that a lot of what we do that isn't so hotsy-totsy is tied to finances. We do more of certain things because we get paid more to do it, not because it's the right thing to do. I can give you lots of examples from oncology. And so I do think we need to pay doctors differently so that they won't have that financial incentive to do things which aren't in the best interests of patients. But we don't know the right combination as to how to incentivize them, the right combination of non-financial and financial incentives. That's one of the things I'll be working on in the next few years. Thank you very much. Real pleasure.
Dr. Emanuel, thank you again so much for tonight's presentation. Thanks to all of you for your great questions. I should say that we were so close at the Institute of Politics to making this an all Emanuel Brothers week. If we had just landed Ari for advice on our Hollywood careers, we would have done it. Tomorrow, downtown at Google, we have an event featuring Mayor Emanuel, Ray LaHood, former Secretary of Transportation, and former Governor of Pennsylvania, Ed Rendell, talking about infrastructure and its role in the 21st century economy. We encourage you to look at that on our website along with our other events at politics.uchicago.edu. We have books here for purchase as well out in the lobby, and a reception afterwards so we can continue the conversation. Thank you all so very much for being here, and we hope to see you again soon.